Hello, I'm Greg Rillet. I'm Professor of Cardiovascular Medicine at the University of Liverpool, and I'm here to talk to you about atrial fibrillation management in 2020, and it's easy as A, B, and C. What does that mean? The steps for a holistic approach to risk stratification and management of patients with atrial fibrillation requires consideration of stroke prevention, assessment of symptoms, because these days we are managing patients' symptoms, therefore this raises the issue about rate control or rhythm control for managing atrial fibrillation. We of course have patients with atrial fibrillation with multiple cardiovascular risk factors and comorbidities, and attention is required to address these risk factors and comorbidities. Real-world management requires therefore simple and practical decision-making processes. This is of course the patient pathway for an integrated approach to manage atrial fibrillation in a holistic manner. This is important because patients with atrial fibrillation present to general practitioners very often asymptomatically. They may well present to the emergency room and be managed by non-cardiologists, even perioperatively or in the critical care setting by intensivists or by surgeons. They may well present to cardiologists, and even within the cardiology department they may be managed by non-arrhythmia specialists and arrhythmia specialists. And central to all this is, of course, our atrial fibrillation patient who is getting information from a number of healthcare professionals. Our atrial fibrillation patients therefore need a simple, streamlined, uniform and practical approach to their care and management. This has been attempted in prior guidelines. There have been the so-called domains of atrial fibrillation management which have been proposed in prior guidelines. And indeed, these domains include what we're talking about with regard to acute rate or rhythm control, managing the precipitating factors, assessing stroke risk, assessing heart rate, and managing symptoms. And some of these lead to improved life expectancy. Some, of course, lead to improved quality of life, autonomy, and social function. But it's important to have a simple message on how to deliver and operationalize this across the patient journey, across the patient pathway, and simple enough for patients to follow as well as non-specialists. That's very challenging, but can I propose that this is as simple as A, B, and C? Well, the ABC pathway, or otherwise the atrial fibrillation better care pathway of integrated care, let me take you through this. What is A? A is avoid stroke, or A is anticoagulation. And that's quite simple because with atrial fibrillation patients, given their high risk of stroke, the default should be to offer stroke prevention unless they are low risk. So the first step is to identify the low risk patients who do not need antithrombotic therapy. Subsequent to that, the next step is to offer stroke prevention to patients with one or more stroke risk factors. Of course, if you're offering stroke prevention, which is anticoagulation therapy, you have to assess bleeding risks and act accordingly. You then have to make an informed decision about your anticoagulation strategy, and anticoagulation can be delivered either as a vitamin K antagonist such as warfarin with good and well-managed anticoagulation control with a high time in therapeutic range. Otherwise, these days, increasingly use of a NOAC, a non-vitamin K antagonist oral anticoagulant, sometimes called a DOAC, direct oral anticoagulant. Well, that's the A of the ABC. What is the B of the ABC? B refers to better symptom management, and this is patient-centered and symptom-directed decisions on rate control or rhythm control, because for the majority of atrial fibrillation patients, we are focused on improving symptoms. So let's turn to the C of the ABC. Well, patients with atrial fibrillation are commonly elderly and they have multiple comorbidities, and atrial fibrillation patients, in fact, are typify the multimorbidity state. So the C of the ABC pathway requires optimization and management of cardiovascular and comorbidities. This includes the management of hypertension, heart failure, diabetes, cardiac ischemia, sleep apnea, etc. Attention is required to lifestyle changes like managing obesity, regular exercise, alcohol or stimulants, and not to forget the patient's psychological morbidity. And central to all this is the patient, him or herself, and their patient values and preferences with shared decision making. Well, this ABC pathway is, of course, easy and simple. That can be proposed simple as ABC. The important aspect is how to operationalize this. And this has been in many ways. For example, in the West Midlands Academic Health Sciences Network, supported with Public Health England and NHS England, is the primary care clinical pathway for atrial fibrillation detection and management. This refers to the efforts to detect atrial fibrillation, and there's the aspects of risk stratification, such as using the CHADS-VASc score for stroke risk, the HAS-BLED score for bleeding risk, and then the next step is the ABC of atrial fibrillation management. A, avoid stroke with anticoagulation. B, better symptom management. And C is cardiovascular and comorbidity risk management. This is atrial fibrillation detection and management on a single page and issued by the West Midlands Academic Health Science Network to primary care and non-specialists. Era of smart technologies, and in 2017 we performed and published a pilot using an app and smartphones which integrated clinical decision support, education and patient involvement strategies, and in this pilot this significantly improved patient knowledge, drug adherence, quality of life and satisfaction with anticoagulation. It's all very well having a concept like the ABC pathway. There's all very well having one-page leaflets and smart technologies like apps. Does it actually make a difference to patient care? This has been studied in a number of observational cohorts, and in the interest of time I will highlight the Atro AF study cohort. This was an Italian cohort published in 2018 by my colleague Daniel Pastori in the Mayo Clinic Proceedings. This was a prospective single-center cohort study with under 1,000 consecutive patients with atrial fibrillation. And the ABC compliant patients compared to the non-ABC compliant patients were associated with a significant reduction in the composite cardiovascular outcome. The hazard rate for major adverse cardiac events was 0.44. In other words, over 50% reduction in the composite cardiovascular adverse event outcome. You ask quite rightly, which is more important, the A or the B or the C? Well, the response is all three are important, because we also analyzed this because we compared for the A, good anticoagulation control. This was a warfarin-based cohort, so good anticoagulation control doing significantly better than poor anticoagulation control. For the B, we looked at ERA score for symptoms, so those with no or mild symptoms, ERA score 1 to 2, doing significantly better than those with poor symptom control. And for the C criterion, those with cardiovascular comorbidity management doing significantly better than those who did not have the appropriate comorbidity optimization. The best outcomes, however, with having the all three, the ABC compliant compared to non-ABC compliant. We have also looked at the ABC pathway in clinically complex patients, and we use the AFFIRM trial. This was an old clinical trial which was well performed, but nonetheless important because we have adjudicated clinical outcomes and and good follow-up. And in over 3,000 subjects, where we looked at the complex groups, which are included multimorbidity, those with polypharmacy, and those who've had hospitalizations, in all the three complex groups, compliance with the ABC pathway was associated with significantly better outcomes, the composite of all-cause hospitalization and mortality compared to non-ABC compliant patients. And if you do look at the components of the primary outcome, whether it's hospitalization or mortality or cardiovascular events or any event, the ABC compliant patients did significantly better than the non-ABC compliant patients. We now have the ABC pathway tested in different populations, and recently published was an assessment of compliance with the ABC pathway in the Middle East population. This was from the Gulf Safe Registry. And if you look at the outcome of all-cause death, or you look at the outcome of the composite outcome of ischemic stroke or systemic embolism, all-cause death and hospitalizations. At 12 months follow-up, there was, again, over 50% reduction in all-cause death. There was just under 50% reduction in the composite outcome by being ABC compliant compared to the non-ABC compliant. Now, there of course are a number of these observational cohort studies or retrospective analysis of trial cohorts. How do we be definitive about the benefits of complying with the ABC pathway, and also to integrate the patient journey, including the detection of atrial fibrillation? Let me introduce you to the MAFA program that we conducted in China. This included firstly the pre-MAFA phase, which was atrial fibrillation screening using smartware. This was published in 2019 by my colleague, Professor Guo, as the Huawei Heart Study. This was published in JACC, a Journal of American College of Cardiology, in 2018, with regard to the pickup by smartware of atrial fibrillation in the general population. Patients with atrial fibrillation who were detected entered into the MAFA-2 trial. This was a cluster randomized trial comparing usual care versus integrated or holistic care based on the ABC pathway. A, avoid stroke with anticoagulation, B, better symptom management, and C, cardiovascular and comorbidity optimization, including. And in the MAFA trial, the primary outcome with regard to the composite outcome of ischemic stroke, thromboembolism, death and rehospitalizations, the patients allocated to intervention with the MAFA integrated care approach had a significant reduction in composite outcome compared to those managed with usual care. The hazard ratio was 0.39, and this was clearly statistically significant. The principal secondary outcome was hospitalizations. This was also reduced by over 65% in favor of the active intervention with the MAFA app with the ABC pathway compared to usual care. Now, the components within the ABC pathway are also relevant to some of the outcomes related to atrial fibrillation. Take, for example, bleeding risk assessment, and we have a number of validated bleeding risk assessment scores. The best validated and recommended by PCORI, Independent Systematic Review and Evidence Appraisal, is the HAS-BLED score for assessing bleeding risk. Now, this was introduced to draw attention to modifiable bleeding risk factors, and importantly to use the HAS-BLED score to identify the high-risk category of patients that should be flagged up for early review and more frequent follow-up. Now, incorporation of the HAS-BLED score into the patient decision aid and management pathway within the MAFA app resulted in a lower risk of bleeding events in the active intervention with the MAFA app compared to usual care. And contrary to the perception that bleeding risk assessment leads to a reduction in anticoagulation use, what was actually found that in the active intervention with the MAFA app and use of the HAS-BLED score resulted in an increase in anticoagulation use between baseline and 12 months. In the usual care arm, there was actually a decline in anticoagulation use over the 12 months. So, proactive and appropriate use of the HAS-BLED score as part of integrated care approach with the ABC pathway reduce bleeding events, usually by mitigation of the modifiable bleeding risk factors, and furthermore resulted in an increase in anticoagulation use in this cohort from a cluster randomized trial. So, in conclusion, atrial fibrillation management in 2020. Easy as A, B, C? Well, yes, we need to improve the awareness and detection of atrial fibrillation. The management is simple with regard to the default is stroke prevention unless they are low risk. That's the A, avoid stroke, or the A is anticoagulation. Additional decision steps consider symptom management with regard to decisions on rate or rhythm control, and this is ultimately patient-centered and symptom-directed. So that's the B of better symptom management. And the C is cardiovascular and comorbidity risk management and optimization. The A and the B and the C is essentially a proactive and integrated approach to the management of patients with atrial fibrillation, and this leads to improved or better symptom outcomes.